Hi, I'm Felicity, a registered nurse, cosmetic injector and founder of the Fit Injector Clinic. Welcome to my channel and video podcast streaming on YouTube, Spotify and Apple. Today is episode 16 and I have Natalie, founder of Sydney Aesthetic Studio, joining me today. Welcome.
Thank you.
So nice to have you here. Thanks for joining me.
Much.
So, Natalie, you are a registered nurse, cosmetic injector, and you own your own cosmetic clinic in the Sutherland Shire. We met a few years back. We were just counting up off air. We think it's about 5 years ago at a injectors event, and we've stayed in touch ever since. And today we're going to be chatting about your background as a registered nurse, how you became a cosmetic injector, starting and expanding your own cosmetic business. And the main reason I reached out to you was to share your experience of managing a vascular occlusion post-nose filler. Very interesting case.
Very much so.
Now, you presented this multiple times at the Fresh Life conference last year to help educate other nurses on the management of such events. It is such an important case to share for both patients and other nurses on the signs and symptoms of a vascular occlusion and what to look for in an injector when it comes to how possible complications will be managed. So, start by telling us your background as a registered nurse.
Yeah, absolutely. So I've been nursing for almost 14 years, which feels like a lifetime. And prior to injecting, I was in the public health system and predominantly I did a lot of pediatric nursing. So that was my bread and butter. I have never done adult nursing because they gross me out. And I do still dabble a little bit in hospital work just because it's still a massive passion of mine. So that's basically my little bit of history. I've done a master's, done a few other things in education wise, but and
just a few things.
Fell into injecting by chance.
Yeah, tell us, how did you become a cosmetic injector?
Yeah, so a friend from work had started doing it and she said, I think you'd be great at it. So I thought, okay, maybe I will have a crack. So I went and did an extremely short 2-day course in Melbourne.
As everyone does.
As everybody does. I just wanted to get a feel for the industry and whether I'd actually be good at using a needle in somebody's face because it is so different to working in a hospital, right? So I went and did that course and it was just a bit of fate. So when I did the course, I met a lovely anaesthetist and his wife was opening a clinic.
No way.
So they kind of took me in. We did a whole bunch of training together and sort of learnt through, all of the major brands and things like that, injecting techniques, all that type of stuff, consultation, and did that over a couple of years together.
That's such a good introduction.
It was such a great introduction. It meant that I didn't have to go into a large chain clinic. I did fall into one afterwards because their business model changed and things like that from the original owners. So I did then end up in an unnamed large chain clinic where I think a lot of people end up.
Yeah.
It was still great for skill attainment and,
and the training opportunities.
Absolutely. And just, how frequently you're injecting, the more
that
injecting.
volume, like back-to-back clients.
Absolutely. Yeah. And the more you're injecting, the more confident you are and the better you become at assessing faces and all of those types of things. So that's sort of where I ended up.
Great. Yeah. And then when did you start your own business?
Yeah, so it's almost 3 years. In March, it'll be 3 years.
Yay.
And I think the motivation behind all of that was coming from a large chain clinic. And it was really from an ethical standpoint of not having a cookie cutter approach to everybody's face. It's not something that you can do. Everybody's face is so different and everybody is coming in for a different reason.
Yeah.
And also, I really didn't like the financial sort of build on that and pressure. Yeah. I didn't want to have targets.
Yeah.
And I don't feel like you can on a medical procedure or product. No. It doesn't work and it's just unethical. So that's why I was like, I need to get out of here. It doesn't feel good. And that's why I decided to start Sydney Aesthetic Studio.
Yeah, well done. That's so good. And was it last year? No, the year before that you moved into your new space?
Yeah, so it was about 18 months ago I moved into my new space. So before that I was renting small spaces and I've opened my own clinic with 2 rooms and it's so great now.
Yeah, and now you're covering both. You've got the cosmetic injectables and you've got the skin treatments as well.
Yeah, absolutely. Yeah. And they as well that they absolutely go hand in hand.
Yeah.
So it's a really nice complement and balance.
It's very important. So good. All right, now into the juicy stuff. So I'm going to leave this open-ended to you to basically explain to us, start to finish, the management of this nose occlusion that you had?
Absolutely.
Was last year? No, the year before.
It was December 2022.
Yeah.
So, just over a year and a bit ago.
Yeah.
So I had a lovely lady reach out to me after having nasal filler at a different clinic. It was not in my clinic. And it was about 3 to 4 days post-injection that she'd reached out to me. And after some investigation, I realized that she hadn't had any Hyalase, which is obviously a dissolver of dermal filler.
Yeah.
So she'd had this procedure done and it was in her nose, and she'd been to the emergency department, she'd been back to the clinic twice, and she'd been to her GP.
So she knew something was wrong.
She absolutely knew something was wrong.
Okay.
So the first 24 hours, she noticed that she had quite a significant headache, was getting some erythema, so, quite red all the way around her nose and sort of like creeping up into the middle of her forehead, and had that persistent headache. So she went back to the clinic and they advised her that it definitely wasn't a vascular occlusion and that it was all fine and that she was okay to go home. She started to get more concerned. Some pustules formed another 24 hours later, so she went to the emergency department. And the emergency department were not well versed on using Hyalase, and it's not something they use very frequently.
No.
She was reviewed by plastics and they did do a CT scan on her and did not actually find an occlusion, which was very interesting. But because it was so small, it was probably really difficult to see.
Yeah.
But then the bruising came, the swelling came, the pustules got worse, and then she ended up with me.
Yeah.
And so I was very shocked when the poor woman walked in the door. It was quite an intense experience. She had quite a bulbous bridge of her nose and tip. It was quite
And she must have been in so much pain at that point.
She was in tears. The poor thing, she'd had such intense pain for almost 4 days and it just progressively got worse.
Yeah.
So basically when she landed on my doorstep, I said, I can't let you leave until I at least have a really, really good go at getting rid of this for you because there are further complications that can happen. She could have had further tissue breakdown, necrosis. She might have needed like nasal plastics, I don't know. She could have needed reconstruction.
Exactly.
She could have gone blind.
Yeah.
And these were real possibilities for her because it was so late after being
that's
injected.
what I'm thinking. 3 or 4 days after. This is terrifying.
Yeah, this is a really long time. So I contacted Fresh, obviously, and Dr. John Holbrook was amazing and helped me through the entire process. It took about 5 hours on the first attempt at injecting her, and we used 3 vials of Hyalase.
I've got like goosebumps while you're telling this.
3 vials of Hyalase, and I was really nervous. And I wasn't nervous in using the actual Hyalase. I think what I was more nervous about was I didn't know what product was in her face, so I wasn't actually 100% sure that I could dissolve it.
Yeah.
And I was also unsure about how much damage was already occurring under the skin and whether I was actually going to be able to reverse it by that stage. Was it already done or was it,
exactly.
able to
and
be
also,
done?
Not knowing what product but how much product or exactly where they've injected it.
Yep. Absolutely.
Yeah.
And I was privy eventually to that information, but it still...
But on that first day when you've got that patient, you don't have that information.
So we absolutely just flooded the whole entire area and sort of just lived on a prayer.
Yeah.
When she did walk in, she didn't have capillary refill in any of her nose.
And had it spread right up?
It had spread to about 3/4 of the way up her forehead. And she started to get tissue breakdown. She was getting some sores. Her pustules started to burst. Did she have any like blurred vision at this point? No, but the headaches were extremely intense for her. And interestingly enough, when we had started the Hyalase, almost the first thing that had changed for her was the instant decrease of the headache.
Oh, wow.
And she burst into tears because she just thought, oh, my goodness, I can't believe how much pain I have been in for so long.
Yeah.
And so it took about 4 to 5 hours to get rid of some of it. I mean, we couldn't see what we had gotten rid of, and obviously she became more inflamed. more
and
swollen.
with the skin already being discoloured and bruised,
It was
hard
really
for you
hard.
to assess
Very
that
difficult.
capillary refill as well.
We did get, it was sluggish,
Yeah.
but we did get capillary refill. So we were confident enough to send her home because something was working.
Great.
And then I reassessed her. And this was very late at night. This was between 7 p.m. and midnight.
Oh my gosh. So this is the day one you've picked her up. You've spent 5 hours and used 3 vials of Hylace.
That's correct. Yeah.
Sluggish cap refill and you've sent her home. Yeah.
And then we got her back the next morning at 9 a.m. to reassess the situation. She was a lot more calm.
Did you sleep that night?
No, absolutely not.
And it's like you didn't even inject it, but you've taken on this physically, emotionally.
Absolutely. I did not sleep for about 5 days. I saw her for 5 consecutive days.
Yeah.
And the
It's
following
like just
day,
take a pillow to your clinic and
honestly, I just really wanted to help her because I was so scared that something really more permanent was going to happen to
and
her.
that duty of care, you're like, she's in my hands, even though you haven't done this procedure to her, she's in your hands now, and you're like, I need to get this resolved.
Yeah, I need to get this gone for her.
Yeah.
So on the second morning, we did another 2 vials.
Yeah.
And we were satisfied after that. It was about an hour and a half maybe. And we got, brisk cap refill. It was probably on the 3 seconds, 2 to 3 seconds, but it was far better than it was when she first walked in.
Yeah.
The bruising was significant by that stage because I had added to that. But the swelling had started to already reduce, which was really amazing. And her headache was almost completely gone.
Fantastic.
So the other issue with injecting it probably for me was that we didn't exactly know where the filler had been placed.
Yeah.
So because she'd had sort of an occlusion almost from tip to above her glabella, we flooded the entire area because
I guess you're assuming they've done the full liquid rhinoplasty and they've sort of injected right along the nose.
Absolutely.
Some people even inject, right at the base of the nose. And
absolutely.
Yeah.
So that was the end of the Hylace, but it wasn't the end of her journey.
So 5 vials in.
5 vials of Hylace. And I did see her for another 3 days after that.
Yeah.
And we popped her onto the LED just to reduce some of that swelling and bruising because it was quite intense. And then about a month later, I did start her on a journey of skin needling. And that was because she had a little bit of post-inflammatory hyperpigmentation in some of those areas.
Yeah.
So it was quite reddened, quite dark. And it was a little bit scarred.
Yeah.
We got very lucky. We actually got rid of all of it.
That's incredible.
So
it's just so lucky that she didn't have permanent damage, vision loss, necrosis of the skin.
Absolutely.
After so many days. And I guess something we probably should have said at the start for, consumers listening, not to terrify people, but noses are one of the highest areas for risks of vascular occlusion. I personally choose not to inject noses.
I also don't inject
because I like to sleep at night. Me too. There's obviously that risk in every other area of the face, but the nose puts you at such a high risk of that, especially being so close to the eye. So there's really not that many injectors, in Australia who are actually doing noses.
Yeah.
Yeah.
I definitely don't touch them.
No. No, thank you. No. So I think this is why, this case is so important, and to even think about, what product, why was this, happening, and then I guess looking at, who was injecting.
Absolutely.
In this case. And huge red flag that she did return to that clinic and they've said, everything's fine. When it comes to noses, anything with noses, our ears prick up, right?
Absolutely.
Yeah.
I did feel like I had a slight duty of care to inform that clinic of what I had found, and I did reach out to them, but I didn't have a great response.
That was going to be my next question.
Yeah. Yeah. But as long as she was safe at the end of the day, that was my primary concern.
Yeah.
So,
and then did the patient then recontact that clinic to let them know, like, hey, this was a vascular occlusion?
Yeah, they were definitely informed of that issue.
Yeah.
I don't know where it went further from there,
and whether that changes policies and procedures,
absolutely.
who knows?
Absolutely.
Yeah, very, very scary. And was she, obviously she knew something was wrong, but had she been informed of the risks and what to look for after a treatment?
Yeah, so no, she wasn't informed of what that could be. And at the beginning, probably in the first 12 to 24 hours, she thought she was just having a bit of hay fever and a bit of sinus. So it wasn't a red flag to her at the beginning to reach out immediately to the clinic, because she was like, oh, I think it's probably unrelated.
Totally.
So I think that's the biggest thing, is understanding that your patients need such huge education around this.
Well, they're not the injectors. They're not the medical professionals. We can't expect them to go, oh, that's not a bruise. That's, delayed capillary refill. So really telling them what those signs and symptoms are and really making a point of that, because like that, they might just innocently think, oh, it's hay fever, or it's just a headache or a bit of swelling, and it could be something as damaging and scary as this.
Absolutely. And I think, that's the other thing, is time is of the essence, right?
Yeah.
The quicker that you dissolve it, the better your outcome and the better your result.
Yeah.
So, I mean, I don't know what you do, but obviously everybody should be educating their patients on what vascular occlusions might look like.
Yeah.
And I know that I do that quite significantly with my patients. They might get a little bit scared, but it's really important to inform them.
Exactly.
And the day after, they all get a message as well. So they get a physical copy of aftercare.
Yep.
They get an email sent to them, and then they also get a follow-up text message the next day to make sure that everything is okay.
Yeah. Yeah. Same. Yeah. So much education.
Yeah.
And even at the time of treatment with all my filler procedures, I actually do a complementary LED, which is nice for swelling and bruising, but it also keeps patients in my clinic for an extra, 10, 15 minutes, sometimes a little bit longer. And it allows me to then do a triple check when I take them off the LED. I always, gloves back on and just say, I'm just going to check all that again. And I'm doing a triple check of that capillary refill before I let them go.
Absolutely.
Yeah.
Absolutely.
Yeah. Especially with a nose, I'm thinking there was probably signs and symptoms at the time.
She did note to me that she'd had instant pain.
Yeah.
And it never went away. So that was a big red flag for me. That would have been a massive sign for most of us.
We would have kept that patient in our clinic, right?
Yeah, let's reassess that. Do we need to dissolve that?
Yeah.
Et cetera, et cetera.
Yeah. They would not have left our clinic.
No, absolutely not.
No way. Hope you're enjoying this podcast. Today's episode is sponsored by the Fit Injector Clinic Mentoring Program, business mentoring for cosmetic nurse injectors. If you are a registered nurse who wants to become a cosmetic injector, or an existing cosmetic injector who wants to start their own business or scale up your existing business, I have just launched an online version of my mentoring program with video modules for you to work through in your own time, downloadable information for you to keep, and a strategy call once you've completed that with me for 30 minutes to answer any questions that you have about starting or scaling up your business. If you want to get started, email me at admin@thefitinjector.com.au. So over the last couple of weeks, Nat, we have been putting up those little question things on our Instagram stories for followers to submit. Nurses do like to put questions in there when I get another nurse on the podcast. So we've got some great questions here. So how do you avoid this is a two-part question. How do you avoid injecting a vein causing a vascular occlusion, and do you aspirate each time?
Yeah, so I guess avoiding important blood vessels is number one. So, know your anatomy is baseline. If you don't know or you don't feel confident, don't inject.
Yeah.
Don't even think about putting needle to skin. It's not worth it.
Yeah.
Know your landmarks, and obviously people's anatomy is slightly different, and you can't always, pinpoint exactly where their veins and arteries are, but we have a rough idea.
Yeah.
I always keep my needle moving. I don't know if anybody else does that, but I've always been taught that. It's not necessarily more safe, but you can get a feel for not always puncturing in the same area. And
not putting a huge bolus in one spot.
Absolutely. Tiny aliquots or really small boluses is how I always have been injecting, which is safer. You don't want to put a massive glob of 0.5 mils in a puriform fossa and hope for the best.
and you're in the facial artery. Yeah.
Absolutely. Absolutely. I think the great debate around aspirate versus not aspirate is a really difficult one, because it doesn't technically make you any safer, but I feel like it's my duty of care to do that. So I do aspirate.
It's like a reassurance thing, isn't it?
Absolutely.
And like I've had multiple positive aspirations.
Absolutely. And they could have been an occlusion if you didn't aspirate.
Yeah, and you're like, I was about to put a nice little bolus in there.
Absolutely. Yeah. So I think although it doesn't technically make you any safer, it makes you a more conscious injector as well.
It does.
So you're thinking about what you're doing at all times. Yeah. And I think
it slows you down a little bit. So you're not just like boom, 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 because you've actually got to really, change your hand position and do that. And it gives you that minute to be like, okay, where am I? What's underlying here? Just give you that extra moment.
Absolutely. I mean, I change my needle frequently too. Yeah. And, go slow. Absolutely. Yeah. And that was going to be my final point. Go slow. Why are you in a rush? This is a massive thing. This is somebody's face. And, there's so many risks that can happen. I mean, bruising is just one, and that happens all the time. Yeah. But, a vascular occlusion is huge, and you don't want to give someone one. So the more safe you can make it, just do it.
Yeah. Yeah. Because, those risks to, consumers, those risks are there with, every area we inject in the face. But Absolutely. Yes, there's lots of things that we can do to make the treatment safer. And also knowing, like, I don't know about you, but I really interchange needle and cannula. Sometimes depending on the area that I'm in, whether it's a high risk area, sometimes depending on like the client and like you said, their anatomy too. Yeah. Sometimes if they're an older patient and I'm thinking, they're, and you can already see they've got so many vessels in their face. And I think, I'm just going to use a cannula through here. And also reduce that trauma to the skin as well.
Absolutely.
And then, needle aspirating. A question I do get a lot, because I have obviously posted on YouTube videos of like injecting lips. And then people go, oh, why aren't you aspirating the lips? Well, that's an area that I don't aspirate because the needle is constantly moving. You are very superficial. And it would be very hard, when you're doing your little like linear threads and things like that to be aspirating the whole time you're going. But anywhere else where I'm going down to bone, I'm always aspirating.
100%. Yeah. And I think also it also comes down to product selection.
Yeah.
Are you thinking about your product selection and the patient's indication of what they want done? Dermal filler is viscous, but are we using thick or thin product, and what are you achieving with that? So it's about consideration of all those things. What size gauge you're using of your needle, what size gauge you're using of your cannula, all those types of things before you even think about putting it into your patient.
Exactly. Yeah. Have a plan.
Yes.
Yeah. Good answer. Next question, how does a vascular occlusion occur? What are the signs? And I think we can answer this both for, maybe newer injectors and also for patients.
Absolutely. So obviously a vascular occlusion can occur when the dermal filler is blocking or partially blocking a main blood vessel. So, the main blood flow of arteries and veins around your face. And because of that, you can get tissue breakdown. Obviously, further going into that, we can get necrosis and, cell death or other things like blindness and in extreme cases, death. But I don't know if there has been any deaths.
Yeah, stroke maybe.
Yeah, absolutely. So I think in terms of being an injector, are you looking at the skin? I always look at the skin. I never look at the needle or syringe when I'm injecting. Always look at the skin. Looking at color. Is it blanching, non-blanching? Straight away, that is your first indicator. Look at your patient. Are they in pain?
Yeah.
Their pain should not be that high. And I don't know about you, but I inject a lot of women, and women's pain thresholds are a lot higher than men's. So they're usually pretty chill.
Yeah. So if they sort of jump,
Yeah, absolutely.
Either, you're near something or,
Absolutely. And palpating, can you feel where it is? And do you know how much you've sort of put in there?
Yeah.
Don't be doing large boluses and make sure you can feel where it is and what it looks like. I think that's from a injector perspective.
Yeah.
If you're a patient, thinking about that pain and speaking up. Speaking up, does it look really different? Is it actually a bruise? What does it feel like to touch? Does it look white? Does it look sort of blue tingy? Or does it look like it's turning into a bruise?
Yeah.
Is it really, really swollen? All those types of things is how I explain it to my patients before they leave clinic.
Yeah.
And also like you were saying before, about checking as an injector about your capillary refill. Like that's super important. It's almost the number one sign of making sure that you don't have a vascular occlusion.
Yeah.
Is it brisk? If it's not brisk, don't send them home.
Yeah, keep them.
Absolutely.
Yeah.
And I don't know about you. I've had one or two where I've been a bit, let's just wait.
Yeah. Yeah.
Let's just wait.
Especially those patients that they are, quite vascular, or you would have seen it before where some clients, they do have sort of natural like white patches, like particularly around the lips and things. And then you maybe give them a little bruise and then you think, I'm just going to keep you here and check that a few more times. And, 99% of the time it's fine. It's a bruise. But I would rather keep someone in my clinic than send them home. And then, there's an issue that you've delayed, because I guess an important point to note for injectors and patients that, time with getting this high laser is the most important thing. The quicker we can administer high lasers in these sort of situations, the better the outcomes are going to be.
Yeah, and I think as a patient, you should know that this is available too. So, I say to my patients, if this does occur, which is rare but does happen, we can get rid of it. So you need to reach back out to us. And these are the things you need to look for.
Yeah. I tell them like all the signs and symptoms, what to look for, and what would happen that I do carry that product, and that they would need to come straight back to our clinic if they had any concerns.
Absolutely.
Yeah. And I think it's allowing like patients to know that, unfortunately, yes, this can happen, but this is how I'd manage it, and them having confidence in you that you will be able to manage it, and also that they'll be able to contact you. Yes. The amount of times you hear these cases, the clinic's locked up and they've all gone on a 3-day holiday for the weekend and no one's got a clinic phone or any way of, clients contacting them, is terrifying. I do try and, switch off from work on the weekends, but I've always got the clinic phone on me and I do check that regularly. So if there were any issues, I'm going to come into my clinic, even if it's like you, it's 9 o'clock at night, and I would come in and I would see a patient, of course.
I think the other thing is, I'm sure you do the same thing, if you're going to go on holidays or anything like that, make sure that you aren't doing filler too close to that, because your responsibility for that patient is to care for them till the end of that treatment. If they end up with a vascular occlusion.
And you're already on a plane halfway across the world, but you injected them this morning.
What are you going to do?
Yeah.
And I have heard of those cases.
Same.
So I think it's really important, but also to have a network of friends around you that can also support you and back you if in the event that this happens.
Exactly.
And I think the other thing is just knowing that your patient knows what to look for. That's just the biggest thing, knowing what to look for.
And knowing to contact if they have any concerns.
Yeah, don't leave it.
Yeah, and don't feel like you're annoying us or, it's going to go away. We want to know about it. Even if it is a bruise, I would rather you come back in, I check it, you do an LED just to make sure.
And we're all happy.
We are all happy. Everyone's happy. So does it become less daunting with experience? This person said, I am so scared of a VO.
Yep. Everybody's scared of a VO.
Yeah.
You should be more scared of not knowing how to use high lasers.
Yeah.
So VOs might happen. It will, and the more you inject, the more experience you get, the more likely you're going to have one.
Yeah.
So I think, treat it like it's your Bible. Treat it like it's the last thing you think about at night. Read your protocol on high lasers over and over again. I would even run some simulations in your clinic about drawing it up, and also have more of it on hand than you think.
Yeah.
I always have 10 vials
same.
at a minimum. And that's because I went through 5 in one turn.
And then what if you had another patient calling you going,
one of my patients,
and then you're having to call me or someone else going, can I borrow some high lasers?
Absolutely. Look, I've been very lucky. I haven't had a vascular occlusion on any of my patients, but I have treated 3 of them in the past. So the confidence definitely comes with experience.
Yeah.
And I've been very, very lucky to have that. And I think what's important is to not get so caught up in the actual emergency of the event.
Yeah.
Knowing just that you have to inject, where to inject, that type of thing.
Yeah. And knowing how to draw it up so you're not panicking when you do have to draw it up.
So I mean, in my clinic, I have like a first aid box that I have all of my things in for it. I've got the aspirin in there. I've got my EpiPen in there. I've got all of my high lasers in there. I've got, I don't need this, but I've got a stethoscope. I've got a few other random bits and pieces that if you need to do an assessment of the patient like this, how do you deal with this?
Yeah.
All of these things.
I have exactly the
a
same.
laminated version of the Hylays protocol, all that sort of stuff.
Because in
prepared.
that moment, if you're stressing and your patient's stressing, and even though on the outside you're like, oh, everything's fine, but it is good to even just have it written down.
Absolutely.
So you just know, right, I'm just going to follow these steps, especially for a new injector.
Absolutely.
I guess there's one more thing we could add to the end of that, which would be, this is the advice I give when I am mentoring other nurses who are, quite new as injectors, because I always get that question, I'm so scared of a VO because they've done their hands-on training and they come away terrified, is to book yourself into some courses. There's some really good ones like Face Coach run on complication management. And they go through vascular occlusions, but they also go through things like infections, delayed onset nodules, like pretty much anything that can go wrong with filler. And I always recommend, and there's a few places that do similar courses, is to really go and educate yourself on that. And then, like you said, just practice drawing up some Hylays as well.
Absolutely.
And have that, have a kit. I have the same as you in my clinic with everything that we need in there. Yeah.
And on that, I think also like associating yourself with someone like AMET as well, having a backup.
Have that support.
And that 24-hour support. And just knowing that you know what to do in the event is it's like doing a resuscitation, right?
Yeah.
The more skills you have around it, the more times you practice it, the easier it gets in the event that it happens. And it is unlikely, but the more you're injecting, the more likely it becomes.
So be confident in how you'd manage it.
Absolutely.
Yeah. Next question is, do you prefer to dilute your Hylays with bariostatic saline, normal saline, or lidocaine?
Yeah, so I always carry 1% lidocaine. Yeah. So I've always done my Hylays with that.
Yeah, me too.
And mostly because of patient comfort.
Yeah. It does burn a bit.
Absolutely. And they're already in so much pain.
Yeah.
You're trying to reduce that.
Yeah. And if you often have to do,
multiple rounds,
5 vials.
Absolutely.
Yeah.
Absolutely. It's just about patient comfort. I mean, in the event that you don't have it, you can absolutely use normal saline. And I would definitely not use 2% lignocaine. I know Dr. John Holbrook talks about this all the time at length about it being potentially cardiotoxic. Yeah. So, your 1% is sufficient enough, especially if you're doing like I did, multiple rounds.
Exactly. Yeah, so, you've got to think about where's that limit for that patient. Absolutely. How much lidocaine have I given
Because
them?
we could have gone another 5 rounds over another couple of days or even on that evening if I couldn't get any capillary refill.
Yeah, exactly.
So I think, for patient comfort, I always use 1%.
Same. I do 1%.
Yeah.
Even if it's like correction work,
same.
Migrated lips and things like that, again, just for comfort.
Yeah, because it's a lot more stingy than getting just filler.
Yeah.
It's a bit like, ooh.
Yeah. So it is good to, anything we can do to make treatments more comfortable.
Absolutely.
So Nat, when we organised this podcast and we wrote these podcast notes, it was before we had these very abrupt changes from TGA, which came out last week. And off air, when you arrived, we were sort of doing our heads in on how we would explain this case without using the word dermal filler, which we're apparently not allowed to say anymore, even though it is a vascular occlusion which is caused by dermal filler, and that we didn't want to confuse patients with them maybe thinking that it was anti-wrinkle that caused a vascular occlusion. So, as a little addition to this podcast, how are you feeling about these recent changes?
Yeah, I agree with you. I think it's becoming really difficult to educate patients, and I think without the use of that terminology, patients will become extremely confused. It's going to convolute the way we use it and advertise and educate our patients on safety aspects of these treatments.
Yeah.
I understand that there's a really big issue around advertising S4 medications and medications that require prescription, and I'm all for that. But I think from this point of view, I don't think that this is actually looking at patient safety, in which the TGA has said on multiple occasions is their primary concern.
Yeah.
And I'm just not sure where this leads to and how we can better educate people. I feel like this means that they're going to need to be looking offshore for their educational status, and also how do we then as practitioners make it safe and offer those treatments and give that education without the ability to say those things.
Yeah, without sounding wishy-washy and confusing. And I guess these words are descriptive words, which we've used for, a really long time, because for those who don't know, in Australia, under the TGA regulations, we cannot say the brand names of these products, which is fine. And I feel like patients understand that. But now taking those descriptive words away, how do we differentiate between the treatments that we are providing?
Absolutely. And I think that as, more people get involved in wanting to get cosmetic injectables, they will fall into this category of sort of misconceived ideas, not sure about what this might be, or what am I signing up for, or what am I booking a consultation for? I don't know what I need. And I understand we all do thorough consultations and we all need to provide those. And I know that that's where the TGA was moving with that type of thing. But sometimes they just want to understand how something works and what the risks and side effects might be, or the benefits to some things. And if we can't provide that through either, any types of media, social media, websites, all those types of things, those people are missing that mark. The general public don't understand what that means.
And they might be really confused whether we even provide the treatments that they're looking for at all.
Absolutely.
Yeah. And I'd really appreciate some more information from the TGA. Like give me a rationale as to how this makes treatments in the chair safer for patients.
Give me a rationale for that, and also give me the terminology that is okay to use, that it's correct.
Because this, we can consult you on reducing wrinkles. Now, not all of our patients want to reduce wrinkles. Some people want symmetry correction. Some people may have had surgeries. They've got scarring. Like, there's so many things we do beyond wrinkles. So I feel like we've been kind of generalized in what we do as well.
And I also think on top of that, a lot of beauty industry, like skin therapies and things like that, claim the same things.
Yes.
So are we delving and tiptoeing into a really dangerous territory of the underground world, of people using illegal products, using things that aren't approved?
Yeah. Why don't we look at regulating that? What about the people importing products that aren't TGA approved?
Absolutely.
Why don't we look at people's qualifications? What is a standard level of qualification to be an injector? What does your clinic look like? Do you have an actual set up clinic, or are you doing this, in your lounge room?
Yeah. And how are you providing your patients the confidence that you know what you're doing?
Yeah.
And all of that is based on that.
Yeah.
What's your background? What's your knowledge? What's your education? And what products are you using? And where are you getting them from?
Yeah.
So I feel like it's quite a dangerous area if not used correctly. So I feel like getting more information about what the correct terminology is and what we can use will be better, but I don't think that it necessarily makes the industry a safer place for patients.
I like what you said before. I think it's almost blurring those lines between us and beauty treatments, and nothing against those. And I do so many skin treatments in the clinic, but if they really want to separate that and make us a very medical, will give us some proper terminology to use. Because when it comes to, reducing wrinkles, well, I've got a whole heap of skin treatments that help to reduce wrinkles. So, but, how do I then talk about the medical side of the cosmetic injectables that I do?
I agree with you.
Yeah.
And how do we differentiate that? You need a degree to be able to be a cosmetic injector, where you only need diplomas and things like that to do skin treatments.
Yeah.
And this is the whole push about not using generic or brand names of our products that we inject, was to be really specific that they are a medical product, a medical prescription is required. And now it feels like we're going a little bit backwards in the ability to actually describe
exactly
what we are able to do with them and what they can provide patients. Not necessarily saying you should get that. It's not an advertising campaign. It's more about what can be done.
Exactly.
And these patients won't know.
Yeah. And do you feel like, because last year we had AHPRA changing some regulations and now you've got TGA, but they're kind of contradictory, because AHPRA was saying on social media that we need to be a lot clearer about what the treatment was and actually use more descriptive words about exactly the treatment the patient was having. And now the TGA is saying we can't use these descriptive words. So I'm like, are these guys, like, do they sit down and have like a board meeting or something? Because now I'm really confused.
And if we're confused, how does the general public feel?
Exactly. What about our poor first-time patient who's trying to, scroll on a website or social media and work out whether you provide these treatments or not, and wanting to know, what the difference is. And I don't know about you, but often for a first-time patient, they don't even know the difference between anti-wrinkle injections and dermal filler. And the fact that we have a description on our, website and social media on the differences of those, that helps to educate them. But now it's like, it's just going to sound wishy-washy, isn't it?
Yeah, I feel like what it's sort of done is sort of dumbed it down a little bit, if that makes a bit of sense. Yeah. We sound like we don't know what we're talking about, but we do. We're just not, we're sort of like, we're gagged. We're not allowed to say a specific thing. It sounds a little bit silly. I have to really think.
Like we're forgetting our words or something.
Yeah, because you need to now describe it in a really long way that's not quite accurate.
Yeah.
So that person is not actually getting adequate information. They're not getting educated.
And how does that give them confidence in us? They might think, does she even know what she's talking about?
Does she know how to use a needle?
Is it her first day?
But I'm curious as to a follow-up statement in regards to it about how this is going to benefit patients and what terminology is acceptable, because a lot of people are going to have to change their social media, their websites, their signage. There's a large amount to it, and where does it stop?
Exactly.
And I don't think it's going to stop. And they have not necessarily threatened, but they've spoken a lot about there being a lot more regulations around the cosmetic industry. So I suspect there will be more of this.
Yeah.
But it's about where does it stop in relation to how does it create patient safety?
Yeah.
But when does it stop becoming taboo and then leading into a dark avenue, if that makes any sense? I don't want it to be this whole, we can't say this, so we're just going to say this, but it makes no sense.
Exactly.
Type of world.
Yeah.
Yeah. We just need better communication from the TGA to help us describe and give patients information.
And regulate the things that actually have a direct implication on patient safety. I'm all for that.
Absolutely.
Tell me what further qualifications I need, come and assess what products I'm using in my clinic, all of, make sure everyone's using a, certain, products, prescribers, whatever it comes down to. But words on social media,
and it doesn't really do the patient any justice by making it wishy-washy and not helping us to educate them and not helping us to give them clear guidelines of what they can and can't have.
Yeah.
And yes, absolutely, everybody needs to come in for a thorough consultation. Yeah. You could book in for 10 things and think you can have all of these, and when you come into my clinic, I can be like, no, you don't need all of these. You'll probably say no to 9 of them. Yeah. And we can start with this and then go from there. And these are all the risks and complications associated with it. Give them complete informed consent and then go ahead with their treatment. Exactly. But if they don't understand what they're coming in for at all, A, why would they come in at all?
Yeah.
But B, how do they know what's on offer?
Yeah.
How do they know what can be done for them, not what should be done for them?
Yes, exactly.
Yeah. I have a few questions for the TGA.
Me too. And we do have a webinar tonight which will hopefully give us a little bit more information.
Yeah.
And I just hope over the next few weeks that the TGA do provide some more information for injectors and clinics.
Some clarification and perhaps maybe some consultation prior to making these decisions.
Yeah.
Wider consultation about what we as injectors think and what we know to be safe.
Yeah.
Is it a bunch of people in a boardroom making these decisions? I don't know.
Who knows? Thank you so much for tuning in to episode 16 of this video podcast series. You can find us on YouTube, Spotify, and Apple. A huge thank you to Natalie for joining me today.
Thank you so much for having me.
Thank you so much for sharing your story.
You're so welcome.
I really hope it helps new injectors or all injectors and also patients out there on these types of treatments.
Me too. Thank you so much for having me.